Now this topic really gets my blood boiling, okay? And anyway, all right, so again, moving on to hematology. Hopefully everyone's downloaded this. Objectives. Okay, let's talk about drugs that are going to be affecting the ability for the blood to either stay nice and thin, or it can flow easily, or talk about things that are actually going to be stimulating coagulation to occur. So first off, I want to talk about going to be the antiplatelet agents. Now again, keep in mind when I say anticoagulant, it's different than antiplatelet. These are specifically agents that are going to be working on the platelet to prevent platelet aggregation, which we know is one of the critical steps for clot formation. Okay, the coagulants we're going to talk about later are going to be specifically affecting things like the actual clotting factors themselves. So you guys remember the big clotting cascade you guys all had to memorize last semester? That's going to come up again here, okay? Just be aware. So anyway, hemostasis, we know there's got to be a nice balance between the two. You don't want to clot off everywhere. You don't want to have free bleeding everywhere. So it's important to make sure we have a nice balance between this. And typically, if a thrombi does occur, you need to be able to reestablish that fluidity, right? So again, if you have something like, an ischemic stroke pops up due to a big blood clot in the brain, you need to be able to get rid of that. So we'll talk about agents that can help with that a little bit later on. But again, you're going to find that for some patients, they need to be on chronic use of things like antiplatelets and anticoagulants. Other patients are going to need this just for the treatment of an actual active thrombosis that's occurred. We'll talk about the differences there as we move forward. Now, typically, what's going to happen here is when you have an actual injury to the blood vessel itself, you're going to find that the first thing that occurs is going to be vasospasm, typically mediated through things like thromboxane A2. Anyone remember where thromboxane A2 was produced? We saw it in the last slide set. Cyclooxygenase actually helped to produce thromboxane A2, right? So it's one of the products of the arachidonic acid pathway we saw earlier. Now, you're going to find that when you have injury done to the vessel, you're going to find that certain mediators get released, or not get released, but are exposed. And you're going to find this is actually what's going to start the binding of the platelet plug, right? So lots of mediators and collagen are going to be involved with the actual platelet plug itself. After that, what helps to stabilize the clot? Fibrin, right? So again, fibrin is going to be kind of the spider webbing that kind of keeps it all kind of there right at the site, and it's going to help stabilize that clot. And then when you want to get rid of that, say you've repaired the vascular cells, what do you want to do after that? Right, what do you call that process? Fibrinolysis, right? So you want to use something like plasmin to actually break down that fibrin, and then the platelets can be digested, get rid of, and then you're good to go again, right? So again, we're going to be looking at kind of ways we can affect this process all the way throughout, right? So whether from the platelet side, from the clotting factor side, from the plasmin side, we can affect this whole process here with a host of many different drugs. And again, we talk about this here because, again, this is going to be the lead into cardiology, which is so important because, again, cardiology, a lot of blood involved with that, right? So again, you think about things like heart attacks, and you think about things, like AFib, and you're worried about things like clots forming. You're going to be using a lot of these anticoagulants and antiplatelet drugs in conjunction with a lot of these other cardiology drugs together, okay? Now, again, I'm not going to do this whole process here, but just remember there's going to be a lot of different mediators that are going to be involved with this. We know that cyclooxygenase is going to be a big thing. We know that things like adenosine diphosphate, or ADP, is going to be a big player here, especially with platelet activation. We also know that it's very important that we get rid of these clots when they form, and this is where things like plasmin is going to be very, very important here, okay? So looking at hemostasis, how we normally keep the blood vessels, or keep the blood from clotting. Normally the endothelial surfaces are very smooth. You have a nice glycocalyx layer that keeps things from adhering to it, which is good. And you normally have thrombomodulin. This is going to be a good inhibitor of coagulation that occurs within the blood vessels itself. Not only that, but also is going to do things like bind to thrombin, and actually activates protein C, which is another factor that gets made within the liver, and that actually will inactivate factors 5 and 8. Again, the details here are not quite so important for this specific factor. However, when we do get into individual drugs later on, and I say, hey, this inhibits 2, 7, 9, and 10, those are good things to know, okay? Or I say this is a direct 10 inhibitor, those are good things to know. Okay, so the mechanism of action is going to be important here, as we'll see as we go forward. Anyway, other things that are going to help to keep the blood from clotting inappropriately is going to include antithrombin 3. This is actually going to work to deactivate thrombin and activate a lot of other clotting factors. This is going to be really important when we talk about heparin, right? Heparin is a normal body product that our body produces, but it's also going to be a drug that we're going to administer when a patient does have a clot. Okay. I mentioned heparin here. Has a very good activity. It increases. It's kind of a coenzyme almost, or facilitator of antithrombin 3, and you see it increases the activity quite dramatically to decrease the function of factors 12, 11, 10, and 9. Those will become important later when we talk about the heparins. Other things, we have things like prostacyclin or PGI2. This is also something that gets produced along the arachidonic acid pathway that actually inhibits platelet activation. And then you're going to see on the flip side of that, you have things like thromboxane A2 that stimulates platelet activation. Plasmin, as we know, is going to actually lyse those clots and get rid of that. A lot of the drugs that we have, if you have a clot, say like an ischemic stroke or something, to get rid of those clots, we use drugs that actually directly stimulate plasmin production. And there's lots of other factors. You have lots of pro-anticoagulants. We're going to be focusing on the drugs that directly interact with those as we go forward. Okay, so let's look at the clot formation itself. We're going to focus on the platelets. Now, normally what you're going to find here is you have a resting platelet. It's going to be kind of floating along in the vessel, no problems going along. All of a sudden, you have an injury. These are things like von Willebrand's factor is going to be expressed here, and it's going to bind to the platelet. This is then going to release or cause the actual activation to occur. And remember that normally the platelets themselves are pretty kind of globular in shape. They don't really have the ability to interact with other platelets. You have a conformational change that occurs here, right? They kind of shrink in, and you're going to see that certain receptors are going to be expressed here, things like 2B3A, and that's going to allow for these platelet cross-linkings to occur here. So a lot of the things we're going to be using as an antiplatelet agent is going to be blocking specific receptors, either to prevent the platelets from causing that conformational change, or to prevent, once they've actually caused that change to occur, prevent them from binding together. Okay, those are the two main pathways we're going to be focusing on here. As I mentioned, I already talked about these, but again, thromboxane A2 and ADP are going to be some of the big ones, big players here that actually cause that conformational change to show 2B3A. And again, this is going to be big for one set of drugs we'll talk about a little bit later on. Again, fibrinogen is also going to help to form that cross-link there. So fibrinogen will help to bind those platelets together using that 2B3A cross-linking there. As I mentioned, you're also going to have ADP, and then we'll talk about thromboxane in a few minutes here. Okay, so this is a good table or a good image to kind of show you the different ways that different drugs are going to be interacting with the platelet itself. So for instance, you imagine here we just have a normal platelet. Here's going to be the things that can interact with it, either causing activation or inhibition. And then you're going to see here's that 2B3A cross-link that occurs with fibrinogen, right? So we're going to find there's a group of drugs that actually will directly inhibit that. Okay, so again, we're going to specific on the details here. So you can kind of refer back to this, and this will help you kind of delineate, okay, how are these different drugs actually working on the platelet. Okay, just some pictures of platelets in kind of their normal before activation versus when they are activated. Those nice little kind of feet kind of hanging off of it are going to be good for grabbing onto other platelets and causing that initial clot to form. All right, first drug, kind of the prototypical antiplatelet agent we'll talk about is going to be aspirin. Now, remember, who do you not give aspirin to? Yeah, kids less than 16, specifically when? Yeah, when they have a viral illness, right? Because you worry about Graves syndrome, right? It's a good board style question. Good to know. Now, basically, the way this is going to be working, and we talked about it before, what's kind of the difference between, say, aspirin working versus any other, like, say, NSAID? Irreversible inhibitor. That's what makes it well suited for antiplatelet sort of effects, okay? Because again, we're not focusing on it as an anti-inflammatory here. We're specifically looking at its effects on the platelets. Now here, we're going to find that by working on which enzyme system? Cyclooxygenase, right? I heard no giggles. Perfect. Fantastic. I'm driving it out of you. You're going to find that it will decrease the production of thromboxane A2. We mentioned thromboxane A2 actually stimulates platelet activation. By decreasing the production of thromboxane A2, because now I've inhibited the cyclooxygenase enzyme, you're going to find that's going to occur for the life of that platelet, right? As we said, 7 to 10 days or so for the lifespan of a platelet. You're going to find that through COX-1, you're going to be inhibiting that and preventing activation of that platelet. Now, does that mean that platelet cannot be activated? No, it just means it's not producing thromboxane A2. It just means it's going to be less likely to be activated overall. There's still, and this is why sometimes you're going to find we'll use multiple antiplatelet drugs together in order to get some synergism there. Okay, so just know that you can sometimes add this on something else. Aspirin may not be sufficient on its own, as the case may be. Now, it's interesting, though, we said prostacyclin, PGI2, actually has antiplatelet effects, but if you drive the dose up aspirin high enough, you actually end up starting to inhibit that as well, and that was actually through COX-2, so we actually don't want those effects. And again, when you look at dosing of aspirin for, say, cardiac protective purposes, how do we dose it? 81 milligrams, or otherwise known as baby aspirin. Just give them a baby aspirin a day. We don't need a lot of it around to sufficiently inhibit platelets from the COX-1 standpoint. But if you drive the dose up higher, you're going to find you run into some issues where you have less prostacyclin being produced, and that's going to kind of bite yourself in the foot, so to speak, where you're not going to be producing, you're not going to be quite as effective there. Okay. You get maximally just 160 milligrams a day. Any higher than that, you're going to start to be sort of counterproductive in that regard. So again, looking at this, we're going to find that thromboxane A2 is the main target we're going to be focusing on. By aspirin coming in and preventing production of thromboxane A2, you're going to find that it will lead to less platelet aggregation and activation overall. That's the main mechanism we're looking at here from a cardiac standpoint. Again, looking at the COX activation pathway, again, we have membrane phospholipids liberating arachidonic acid. And cyclooxygenase is going to play a role here, and we see where both have thromboxanes, prostacyclins being produced here, and also things like prostaglandins. We've covered, the utilization of these as well. If you see RBF here, you probably know what RBF means, but in the context we're talking about here, this stands for renal blood flow. So if you remember, prostaglandins did things like vasodilate the afferent arterial, things like that. That's what that's referring to there. Again, we're not really talking about the kidneys so much here, but just know that the prostacyclin tend to be an inhibitor of platelet aggregation. Thromboxane was actually increasing aggregation there. Okay. Now, as I mentioned, aspirin is going to acetylate both COX-1 and COX-2, and it'll be an irreversible inhibitor. We don't really care about the COX-2 effects here from a cardiac standpoint. However, that could be important if you're using bigger doses. The patient was having some inflammation there. So those are the big things to take away from that. Just know the COX-2 effects here. Again, as you drive the dose up higher, more COX-2 inhibition, less prostacyclin being produced, more likely to see platelet aggregation occur. Now, just to compare the effects between an NSAID to aspirin, you can see the duration of action from an antiplatelet sort of effect. And what do we say about the other NSAIDs? They're reversible, right? So I can give a patient ibuprofen, I can give it to that patient, and you would see antiplatelet effects, because we said what's a side effect of NSAID use? Bleeding, bruising, right? So again, any of these antiplatelet agents, bleeding and bruising is going to be the predominant sort of side effects you're concerned with, right? However, it's going to be a short-lived sort of effect. So if I gave a patient ibuprofen, maybe only 24 hours worth of effects should go away over time. However, the aspirin is going to be for the lifetime of that platelet. So 7 to 10 days is how long you're going to see that duration of action for, okay? Now, as far as side effects go, we know certainly from a GI standpoint, there's going to be some issues. Why would aspirin affect the GI tract? Decreased prostaglandin synthesis is going to do what? Yeah, decrease that gastroprotective barrier, right? So again, usually 81 milligrams a day, probably not going to be a big issue on your patient from that standpoint. However, it is a concern, right? You want to be saying, well, if you have a history of peptic ulcers, things like that, maybe this is not a great drug. Oftentimes, the benefits of low-dose aspirin is going to outweigh any potential GI side effects, or I can give patients drugs that are going to be counteracting the GI effects, as the case may be. But we worried about peptic ulcers with NSAIDs. Also, you have to worry about with a drug that increases your propensity to bleed. You have to worry about that, right? Bruising can occur up into 40% of patients. Some people are going to be more sensitive than others. Keep in mind, though, if they're on, say, an antiplatelet drug for cardiac protection, then they also get put on anticoagulant, say, for instance, for AFib. Guess what? That bleeding risk is going to go a lot higher, right? So again, bleeding, bruising risk will go higher as you add more drugs together. This is going to be inhibiting this whole coagulation cascade. The next group we have here is going to be the ADP receptor blockers, and ADP stands for adenosine diphosphate. Perfect. There's two main receptors here. There's a P2Y1 and a P2Y12. They're going to find that they have a little bit different action within the platelet itself, but both should help to decrease the aggregation, or in these cases, help to prevent the shape change that occurs there. By keeping it more in the globular shape, you prevent the exposure of the glycoprotein 2B3A receptors there, right? By inhibiting that, they can't form that cross-link with fibrinogen. So those are good things. And you're going to find that you can also have some direct inhibition of fibrinogen as well, and prevent that from actually binding to 2B3A, which is good. And then also some von Willebrand factor. We know that was important when the actual vascular endothelium actually gets exposed there. The von Willebrand will help to kind of kick off the whole clotting, the whole platelet aggregation cascade there. So a lot of actions here. These are actually pretty good drugs. As you imagine, what do you think the bleeding risk would be with these drugs versus aspirin? Probably higher, right? So again, they're going to be more potent because you see how they're working on multiple sites here now. You see how they have multiple actions. They tend to be more potent. However, you're also going to find they're going to be more likely to see side effects associated with it. Now, the four that fit into this category are going to include ticlopidine. This one actually does not get used anymore, and I'll show you why in just a moment here, but it's good for historical reference. And we're going to have clopidogrel, or Plavix. This was kind of the king of ADP receptor blockers for a good long time. And nowadays, though, you're going to still see it being used sometimes, but now often you're going to find that certain drugs like ticagrelor, or Brilinta, and the prasugrel, or Effient, are going to be used in it instead. Okay, we'll talk about why in just a few moments here. Anyway, but they're going to have concentration-dependent inhibition of platelet activation, which means that as you drive that dose up higher, you should see more platelet inhibition. And oftentimes, when patients are going to get have these administered, you actually give a loading dose up front. And again, loading dose does what for us? Yeah, shoots you up to steady state immediately, so that way the platelet should be inhibited almost immediately. As soon as you get that loading dose in the system, it gets absorbed, you're good to go, right, from that standpoint. This is why it's good for things like prevention of stroke and MI, but also we're going to find that very frequently these drugs get used in case of like angioplasty, or in the case where you're having like stents being placed into coronary vessels. Oftentimes ADP receptor blockers are going to be used pretty frequently there. Because one of the things I mentioned is anytime you put foreign material into a patient, what happens? The body reacts to it, right? So it wants to get rid of it typically. So again, if I put, say, for instance, a bare metal stent into a coronary vessel, it's bare metal, platelets and things like that are going to want to bind to it and clot to it, which again, if I cause that to clot off, it kind of didn't do your job, right? So by giving an ADP blocker, you're going to be able to prevent those platelets from binding to it and keep that vessel patent, right? So these are going to be very good drugs to be used, especially patients who have stents placed, and anyone you need kind of more antiplatelet effects than just aspirin by itself, right? Yes, sir.
So why would you want to use that during surgery if it carries a risk of like bleeding?
Yeah, so the question is, why would you want to use it in those cases there? So again, sometimes you have to weigh the benefits versus the risk, right? So again, if I'm using something that's less, say, invasive, say I'm not doing open heart surgery, but I'm just doing something like the patient in the cath lab, right? And so again, I'm just putting in, a line that's going to be snaking up into the heart and getting to the coronary vessels. That's less bleeding risk. The risk is going to be increased, but it's less likely than if you were to say, be opening up the patient entirely, right? So, for those cases there. A lot of times these will also be used after the fact as well. So maybe they're not used in conjunction with the surgery, but they may be used afterwards to prevent the platelets from binding up, right? So again, if I try to put on, do angioplasty, put on a new vessel to prevent any of that from clotting off, you may have these drugs involved as well, okay? And again, we're going to specifically talk about use cases for these later on as we get into the actual cardiology sections and talk about, STEMIs and STEMIs and things like that, okay? All right, so any questions from the last time we met? We cover, what did we cover? We did the eyes, right? Yes, we did the eyes, and then we did start off with the anticoagulants, the heme lecture, basically. So we were covering our antiplatelet agents, right? So what are some antiplatelet agents we covered? Aspirin, probably kind of the main one that we covered already, right? So how does aspirin work?
COX-1 and COX-2.
Yes, thank you. Blocks COX-1 and COX-2. How does it do that? So yes, it's preventing that. Please, listen, I'm taking a new leaf here. No more humor. We're done with all of that. Straight lace farm from here on out, okay? Anywho. I know I talk a lot about like illicit drugs, talking about things like alcohol and marijuana, but you know what? Cocaine is where I draw the line. Anywho, we talked about aspirin. What was the unique thing about aspirin? What made it better as an antiplatelet drug versus, say, like your NSAIDs? Irreversible, right? Again, how long would that be lasting for, the effects? 7 to 10 days, right? Basically the lifespan of the platelet, absolutely right. So again, we're looking at some other mechanisms that we can use to help to decrease platelet aggregation, hopefully prevent clot. So the next group we have here are the ADP receptor blockers. Basically, they're blocking the ADP receptors, ADP being adenosine diphosphate. Perfect. It's going to be blocking the effects and thereby preventing some of the aggregation from occurring here, right? We also saw it's helping to prevent some of those cross linkages from occurring with fibrinogen between the 2B3A receptors there, right? And those are those receptors that get exposed when you have the platelet actually change conformation there. But anyway, the first one we actually don't use this one anymore, but I at least want to illustrate why. And so the first one was taclopidine. And this is going to be, again, most of these are prodrugs that have to be hepatically converted. So a lot of these end up being orally administered medications because of that. Because again, how do you get the most first pass effect? Give a drug orally, right? Because again, that way the whole drug is going to be going through the liver before it really gets into systemic circulation. Now, of course, anything that's going to be antiplatelet, what's a big side effect you're expecting to see? Bleeding, bruising, right? So again, those are going to be the most common things you're going to expect to see. Another kind of interesting one here that occurred with taclopidine is actually this thrombotic thrombocytopenic purpura, TTP. If you ever hear that, it is a potentially life-threatening condition, and part of it was thought to be sort of a immunologic response. It actually has a pretty high mortality if you can't really get it caught early and are able to manage that. And so because of that high risk, it was high enough to where we don't really use this drug anymore. We'll see that's still a risk with some other agents, but it's much less pronounced than it was with taclopidine. So again, the main place where we may see ADP receptor blockers used as well. We mentioned using them for potentially things like if you have like a stent stent placed in a coronary vessel after going under percutaneous coronary intervention, or PCI. Undergoing that, we'll oftentimes give that to help block the platelets from aggregating on that stent. But sometimes if the patient cannot tolerate aspirin, this can also be a good backup to that. The ADP receptor blockers in general can be. So instead, what we used kind of was the workhorse for a good long time was clopidogrel or Plavix, again, another oral agent. Now, again, when you were going, patients were undergoing PCI, they were going to the cath lab. One of the things we would oftentimes do is to try to get the drug working as quickly as possible, right? And so we would do things like give them a loading dose, because loading doses do what? Yeah, it gets up to steady state very quickly. So oftentimes you find patients are getting a really big loading dose up front, and then they'll be put on maintenance dosing afterwards to kind of keep them at that steady state. This also has pretty good synergism with aspirin, right? Because now we're working through two different mechanisms. One's working on the cyclooxygenase pathway, one's working through the ADP receptor blockade. So again, you get better synergy, but also what do you expect to see? More toxicity, right? More bleeding and bruising being the risk you're going to see with that, okay? Again, adverse effects you're going to expect to see: hemorrhage. Neutropenia, pretty rare for the most part. TTP, much lesser percentage-wise as far as when this is going to occur, right? So very low percentage chance there, but can still occur occasionally. Again, other than that, nausea, vomiting, diarrhea, but that's pretty similar with most other drugs out there, okay? Now, are going to be these two other drugs that actually have even stronger antiplatelet effects than Plavix does, and so these are starting to become more and more used more frequently. Plavix has been around for a while, so it's going to be a little bit cheaper, but these other ones are starting to get more and more use. First one being prasugrel or Effiant, again working to block those P2Y12 receptors. Again, synergistic, very similar activities here. You will find that because it is a more potent platelet inhibitor, more bleeding is going to be a risk there. However, that bleeding risk is probably going to be okay compared to the risk of, say, clotting off that stent, right? You don't want that vessel to be occluded again, otherwise the patient can have another heart attack. It's not good. Something kind of more unique side effects is can actually worsen hypertension, right? So if you already had a hypertensive patient to begin with, this may be something you see with that. It can worsen the lipid panel. And again, patients who are developing a heart attack needing a stent placed, what other comorbid conditions they probably have? Hyperlipidemia and hypertension, right? So again, look at their other meds, look to see how well controlled. Just be aware that this could be worsened by adding on a drug like this, right? The other one's going to be ticagrelor or Brilinta. Again, very similar activity. This one is actually not a prodrug, but it does have an active metabolite. When I say active metabolite, what does that mean? It means once it gets metabolized, you normally expect a drug to be inactivated when it gets metabolized, right? That's the whole point of metabolism. Occurring, places like the liver. But in this case, you can actually have active metabolites, but they actually still retain some activity, right? So we're going to find other examples of that through lots of other types of drugs. But this is probably one of the first examples of this, where the drug will be broken down into metabolites, and some of them still have activity as an antiplatelet agent. Again, that can sometimes help to extend the duration of action of a drug. Because again, if you had to expect, which one do you think has a longer antiplatelet effect, aspirin or something like ticagrelor? Probably the aspirin, right? Because we said aspirin is irreversible. As soon as the drug has gone out of the system here, as soon as you get rid of that drug, it's not an irreversible bond we're making to that P2Y12 receptor. You're going to find that once the drug is gone, they can then start to aggregate again. That's why, it's really important patients are taking these consistently, because again, once the drug's out of the system, you're going to find the effects go away, then the platelets can start to aggregate again, right? Whereas the aspirin is going to have a much more kind of longer lasting sort of effect due to that irreversibility there. Other things with this one, obviously, bleeding being a big risk. In some cases you can find increased uric acid. Who might that be bad for? Yeah, patients with a history of gout, or things like, if they had history of maybe uric acid crystals, developing in the kidneys, cause some interstitial damage. That can also be a problem. But yeah, gout's probably the main one. You can see that relegated too. Okay, so those are the ADP receptor blockers. Next up, we have the 2B3A blockers. These are actually agents. Now, the ADP receptor blockers we mentioned typically are oral agents, not used IV. On the other hand, we had the 2B3A blockers, and these are going to be agents that are exclusively used IV, as we're going to see here. So these are good for inpatient use. Patients going to the cath lab very frequently, we're going to get them started on one of these agents to get them have very rapid antiplatelet sort of effects here. Now, the first drug we have here is one called abciximab, otherwise known as Riapro. Now, have you covered any drugs that have an MAB at the end of the name? Yeah, anyone knows what that means? Yeah, it's a monoclonal antibody. Basically, it's an antibody that we have engineered to have a specific target, right? So just like you have antibodies that are targeting things like influenza or the mumps or anything like that, we can generate antibodies that can target specific molecules in the body. In this case, it's actually the 2B3A receptors there. And again, those are the receptors that cause that cross-linking with fibrinogen between the different platelets, right? That's what's forming that platelet plug there. One of the things you're going to note, whenever you have a monoclonal antibody, what type of molecule do you think that is? Is it a sugar? Is it a protein? Is it a fat? It's a protein, right? So it's an amino acid sequence we've developed here. And again, anytime you're injecting foreign protein into a patient, what's a risk? Allergic reaction could be possible, okay? And this is going to become, this will be the same as any monoclonal antibody we run into, whether it's with rheumatology, cancer, anything like that. If you see, it may be at the end of the name, know that it's a monoclonal antibody, know that it's a foreign protein, and there can be a risk for having allergic reactions to it within the body, okay? Just be aware of that. Now, the other thing you can also consider, sometimes the body can actually develop antibodies against it that actually may not cause, like I say, an acute anaphylactic reaction, but can actually neutralize the drug. So in some cases, maybe a drug you may only get one use out of. Once the body is sensitized to, if you were to give it again, the body already has that memory developed where it can then inactivate the drug, and it's going to be ineffective. Those platelets can still bind to one another. So just be aware of that. Anytime you see MAB, know that's going to be a monoclonal antibody. What do you think about the price for having to generate these antibodies? Pretty expensive, yeah. So these agents are quite pricey. We're going to see that with any drug that's a monoclonal antibody. They are expensive. Now, when we see things like humanized, oftentimes these proteins can either be based solely on human proteins. They may be based on things like mouse proteins. Anyone know the I'm trying to think of the word, like the adjective you would apply to like a mouse protein? You know, if I said horse, it would be equine. What would be it for mouse? Murine, yeah. So if you see murine, that's what that's referring to, is actually mouse proteins. But so it can either be based on mouse proteins. Sometimes it can be a chimeric kind of mixture between the two. Which one do you think could be more antigenic? Do any of you like cheese especially? No, you're not mice, you're humans, right? So typically what you're going to find is that when you have more murine-based proteins, you're going to have a higher likelihood to have a reaction to it, right? So again, the more foreign the protein is, the more likely that reaction is going to be. If it's more humanized, if it has a much more human basis, you're going to find they have less risk of that. So just something to keep in the back of your mind. For instance, when we're dealing with snake bites, how do we deal with snake bites? Well, you have antivenom that are basically antibodies. We basically will hypersensitize sheep in these cases against certain snake venom, and then we'll take that out and then inject it into patients essentially. And that, again, you run some risk for having a reaction because that's a foreign protein. If it was human, then we wouldn't have any problems with that for the most part. But just something to think about. And again, this is oftentimes going to be used, with angioplasty, oftentimes in conjunction with aspirin and heparin. Again, this helps prevent that restenosis, or again, prevents that reblockage of a vessel there. Again, the nice thing about this one, it actually even has some activity about 18 to 24 hours after the infusion is stopped. Typically, proteins have a little bit longer duration of action than a lot of other types of drugs. So again, you'd run this as a continuous infusion. Once you're done, then you see there would be another, say, 18, 24 hours of the drug still working, still providing some antiplatelet activity, which can be useful. Another one here is going to be eptifibatide. Now, this one is not a monoclonal antibody. You can tell just by the structure here that it's not. So this may be good if a patient maybe could not receive epciximab because they had received it before. Maybe they were sensitized to it. They could use this instead. Because, again, the body should not be developing any real antibodies against a drug like this. Again, much smaller sort of product here. Same activity, though. You're going to be finding these are typically continuous infusions you're going to be administering to the patients. And, again, typically during acute coronary events, angioplasty, these are where these drugs get their most utilization, typically in hospital, though. Yeah. Again, less immunogenicity. If you had a patient who you're worried about an allergic reaction, this would be a good backup agent to something like epciximab. And then the last drug in this group is going to be tirofiban or aggrostat. Again, still not a monoclonal antibody like epciximab was. You're going to find that this is, oftentimes used along with heparin and other agents because we want some synergy there, as we're going to see as we get into the other anticoagulants a little bit here. This one is going to have renal elimination, so this may not be good for patients with poor kidney function. Maybe you want to use something like eptifibatide instead if that was the case, right? Or something like epciximab that had poor kidney function here. Okay, so those are the antiplatelet agents that are used most frequently out there in the clinical world. Coagulants. So when I say anticoagulant, what am I referring to? Clotting factors, right? So these are going to be drugs that are either blocking the activity, preventing the formation of, or directly inactivating clotting factors that are circulating throughout the body, right? Typically the ones that have been activated in most cases. Now, if you remember the clotting cascade, I'm not going to have you memorize the entire pathway here, but what's kind of the difference between the extrinsic and intrinsic systems? Kind of was kicking off the whole process, right? When you see the extrinsic system, this is where usually tissue factor is going to be the thing kicking that off. Factor 7 is usually the first thing that gets activated there versus, say, the intrinsic is where we're going to find, different stimuli for that to be kicked off. But again, is it usually you have one or the other working? Typically, it's both going to be kind of working in tandem, as you're going to find. But they both culminate in the activation of factor 10. This is that common pathway. They're going to go through 10. Eventually, you're going to have activation of prothrombin, or factor 2 into thrombin. And again, this is the big thing we think about as being kind of the biggest stimulus for coagulation to occur, because that's going to help to stimulate the conversion from fibrinogen over to fibrin. And remember, these are kind of cyclical pathways. These are positive feedback loops, where by having thrombin activated, it's going to feed back and activate things like factor 8. It's going to feed back and activate things like factor 5 in order to help get that clotting cascade going very strong, very quickly, and then it can kind of burn itself out, so to speak, right? So again, another example, positive feedback loop there. So what we're going to find is that a lot of the anticoagulants can either do things like maybe prevent the formation of, so we're going to see warfarin is going to be a good example that does that. A lot of the drugs will directly block the effects of, or actually will help to degrade the clotting factors. As we'll see in a little bit, like heparin is going to be a good one that does that. And then actually, if you actually have a clot already formed, what can we do with that? We got to break down the fibrin, right? This is where we're going to cause fibrinolysis to occur. So we'll talk about that a little bit more when we get to talking about acute coronary syndromes later on. But just know that's going to be kind of the final stage there. If you have an active clot already occurring here, we're going to be able to break that down by using things like TPA. We'll talk about that a little bit later. So anyway, some of the things we have that are natural sort of anticoagulants are going to be things like antithrombin 3. Does anyone remember what I said works along with antithrombin 3 to increase its activity? Heparin, right? So heparin's going to become a big player here as well, as we're going to see in just a little bit. We have natural anticoagulants like protein C and S that are going to be able to help to inhibit the activities of some of these factors. And again, I'm not going to get super specific here. When we get to the individual drugs, I will ask that you know which clotting factors this is going to be primarily interacting with or primarily affecting, because that is important as far as the mechanism goes. It's really important as far as the monitoring goes. It could be really important as far as the reversal goes, right? Because again, with anticoagulants, what's the big side effect I'm really worried about? It's going to kill my patient. Bleeding, right? I do not want them to bleed necessarily, so it's good to know if I can reverse the agent. I want to be able to do that, right? Because again, if I can stop a potentially life-threatening bleed, that's going to be good overall. So let's go talk about the one that is naturally occurring in all of us, right? So we all have heparin within our systems naturally. We can give people exogenous heparin as well, right? And so this is basically a really long sugar molecule. And then whenever you hear unfractionated heparin, this is what we're referring to. It's just the basic, normal, run-of-the-mill heparin that you can get down at the Wawa or something, right? Now, you can't actually buy it there. But does anyone know what animal we typically got heparin from? Pigs was a big one, and then also from some beef sources as well. So sometimes you have to consider, especially with patients with certain religious backgrounds, they may not want to receive products that maybe are based on certain animals, namely pigs and beef and things like that. Nowadays, we have a lot more synthetic varieties, and so we don't have to worry about that quite so much. And I think I have a slide where I showed that in just a second. But this is unfractionated heparin. This is just normal run-of-the-mill heparin. It's a very long sugar moiety that's going to be working, as we're going to see, along with antithrombin to inhibit the activity of several clotting factors. Again, we're going to find antithrombin 3 is going to have the most activity. And again, clinically, the two big ones we're really concerned with are going to be 2 and 10. Okay? So just like when you're driving, where are your hands at? 2 and 10, right? Hopefully. Hopefully not on your phone and on your makeup and using your knee to steer. You don't want to do that, right? You don't want to do that. Hopefully. I see that a lot, though, on the way in. It's very, very annoying. Quite dangerous. But, or maybe like with a drink or something, I don't know. Anyway, so 2 and 10 are the big ones we're really concerned about, right? So these, as we saw, those are two of the big ones that are involved in that common pathway. So if we can eliminate activity in the common pathway, that's going to be get more bang for your buck, essentially. You also find that antithrombin 3 has good activity against 9, 11, and 12. Okay. So heparin is going to work along with antithrombin 3 to try to help inactivate these clotting factors directly. Okay, so I'll show you a slide of what that looks like in just a second. But if I were to ask you what activity does heparin, what clotting factors does heparin work against, you would say 2 and 10, 9, 11, and 12. Okay, 2 and 10 being the most important ones, but then 9, 11, and 12 additionally being affected here. Okay, and again, we're seeing increases in activity by about 1,000-fold, so much more potent antithrombin 3 is going to be working much faster. And we're going to see that the way that these are going to be working are based on specific saccharide sequences. So based on the sugar moieties there, we'll give it activity, and we'll see this becomes important when we actually get to shorter and shorter heparin molecules. When we start to fractionate that heparin, it'll become important as far as what activity is going to have against certain clotting factors. Okay. Anyway, so once the factors are inactivated, they're going to find that antithrombin 3s will be released from the heparin. It can go and interact with another antithrombin 3 and then inactivate further clotting factors. Here's an example of what a molecule of unfractionated heparin would look like. Now, it's a pretty long sort of molecule here. It'll work along with antithrombin 3, so you see there's a binding site for it. And imagine it interacting with both, say, let's say factor 10 is here and then factor 2 is here. Okay, by being able to bind to it, you see you got some extra space on here when working with factor 10A. That'll be important when we get to shorter molecules a little bit later. By looking at these, you can see increased deactivation of those clotting factors, and then you're kind of interrupting the whole clotting cascade, right? So hopefully you're decreasing the amount of fibrins being activated, you're decreasing that propagation of that clot from being generated. Now, does this have any platelet effects? No, it just works on the clotting cascade, right? So again, you may find some of those clotting factors will interact with platelets, but this directly does not cause any antiplatelet effects, specifically just affecting the clotting factor. So as I mentioned, we used to get it from things like porcine, intestinal mucosa, and bovine lung. Fortunately, nowadays I think we have some more synthetic forms. I think if you ever see like Chinese hamster ovary cells, that's for whatever reason, I have no idea why, that's a popular set of cells that we produce some drugs from, some molecules from. Yes?
How do you get to a hamster's ovary to get cells?
I think we can culture them out and actually start to grow them ourselves, like in a vat, almost.
Hamster ovaries.
Hamster ovary cells. As long as you have the cells and you give them the right medium to grow in, they will continue to grow. I don't know if anyone's ever worked in like in a bio lab where you had to culture cells and stuff like that. It's actually pretty gross doing it. But yeah, as long as you have a good broth and you can make sure they have all the stuff they need, you can grow these cells. But anywho, not to digress too far, but anyway, just know that unfractionated heparin, it being a pretty long molecule, it cannot go through the GI tract. And so one of the problems you're going to find with it is that it has to be given parenterally, either meaning it has to be given sub-Q, which is a common route, or it has to be given IV. Okay. It also has a fairly short duration of action. So when giving it IV, typically being given via continuous infusion. So if you hear someone on a heparin drip, that's what we're talking about. Or potentially, if we don't need to have a strong anticoagulant effect, we may give it sub-Q, and that may be intermittently given. So for instance, you may see a patient on sub-Q heparin every 8 hours. Okay. By giving it sub-Q, you're going to slowly leach out that drug into the bloodstream, and then it can have its effect, right? Versus if I were to give it straight into the bloodstream, it's much more likely to be degraded. I have to give it via that continuous infusion to have continuous effect, as we'll see there. Okay. Anyway, nice things about this, it actually does not, because it is such a large molecule, it doesn't cross things like the placenta, the blood-brain barrier, the breast milk, anything like that. So it's actually pretty safe for pregnant patients because the fetus really should not be affected in those cases there. So you may see that. And again, one of the things you'll learn about pregnant patients is they tend to be more at risk for developing clots. They tend to be hypercoagulable, as the case may be. So you're going to find that this can be a concern. You may have to put some patients on heparin who happen to be pregnant there. Okay. Now again, you may find some patients due to things like either renal failure or cirrhosis, liver dysfunction, you may see an increase in half-life. So that's why monitoring is super, super important when we're looking at these agents here, right? Because again, we want to know just how anticoagulated our patient is, because it's a very fine balancing act. Because again, if you go too low, if you don't have enough anticoagulant effect, what do you worry about? Getting a clot, right? If I have too much anticoagulant effect, what do I worry about? Bleeding, right? So again, this is a double-edged sword. You got to really make sure you're kind of walking that fine line, and this is why monitoring is so important here. Okay, so monitoring parameters. The thing we normally use and we traditionally use to monitor the effects of heparin are going to be APTT. This is the activated partial thromboplastin time. Typically, what you're looking for is a sort of ratio, and this is typically measured. Anyone know what the units are on APTT? It's usually seconds. So again, they're looking at the time that it takes to actually cause this clot to occur. So if you see like, say 20 seconds, 30 seconds, whatever, the lab will report that out. Very frequently, you're going to be looking for a therapeutic ratio. So you may see, hey, we're going to titrate this heparin drip to get it the APTT to say 1.5 to 2 times what the normal was for that patient, right? So again, you're taking just what the patient's APTT is, dividing it by the normal one in order to get that ratio there. So that's something you're typically looking for. Now again, where are we going to be using this? If a patient already has an active clot, so say for instance they have a venous thrombosis, they develop a pulmonary embolism, if they're having an MI, angioplasty, where you're worried about them clotting off, these are all cases where you want to have heparin on board. Okay, these are actual treatments that we're doing. So we're actually trying to either start to break that clot down, or we're trying to prevent that clot from getting any bigger, as the case may be. There are also some cases where we can use this for prophylaxis as well, where we can actually, if we want to prevent a patient from developing a clot, we can also give them heparin beforehand, right? So for instance, when might a patient be at risk for developing a blood clot? After surgery is a big one, right? So very frequently we're going to give prophylaxis for clots in the post-surgical time frame, right? Because again, what happens after surgery? What are you doing? Just laying around in bed, right? That's why mobility is so important after surgery. We like to get them up and moving as soon as we can, because when you're laid up for a while, you're going to find that those clots like to sit there and just that venous stasis occurs, and those clots like to form there, right? We don't want that, because again, the biggest worry about venous thromboembolism is what? You throw that clot and goes where? Into the lungs, right? Because it's going to go to the right side of the heart and then back up to the lungs and then to PE at that point. That's what we're trying to prevent in those cases. What are some other cases where you might have a patient at risk for clots? AFib is a good one. That's actually going to be one that's going to be more of a chronic sort of need for anticoagulation. We'll talk about what drugs we use for that a little bit later on. But think about just kind of maybe short-term sort of causes for it. Imagine if you had to fly over to Japan, right? So imagine you had a very long flight you had to go on. Oftentimes patients who are at risk, not young, healthy individuals like yourselves, but some individuals may be at risk if they're, older and they're have a pretty sedentary lifestyle and they're just sitting around on a plane for 12 hours to 14 hours. They can develop clots very frequently. And so sometimes we'll give them prophylactic heparin beforehand to help kind of prevent that. But anyway, so again, anytime you have a risk for developing a clot, you can give this prophylactically, or to treat active clots, heparin can be used for that. Now, as I mentioned, toxicity, bleeding is going to be the most common thing you're worried about. When it comes to anticoagulants, you want to know what the reversal agents are, okay? Because again, if you give them too much, is anyone familiar with, I'm trying to think of the actor's name. He was a couple of years ago, he had a medication incident with his, I think, a twin daughters or twin children that were in the NICU or something, and they accidentally had a heparin overdose. Dennis Quaid, I think it was. Anyone remember that? There's a big medication error where basically a patient got too much heparin, or his twin children got too much heparin and almost had a really bad outcome, right? So again, it's good to know what the reversal agents are going to be, so that way whether either the patient is reacting poorly, something we could not have predicted, or we screw up and we give them too much, we need to be able to reverse that. In this case, it's going to be protamine sulfate. Protamine is basically going to be able to bind to the heparin and then inactivate it, okay? So if I were to ask you on a test, say, hey, patient, nurse comes up to you, so the patient says, or the nurse says, hey, you accidentally gave, 3 times the normal dose of heparin that I didn't mean to. What drug do I kind of give to reverse this? You would be able to say protamine sulfate is the correct answer there, right? So again, know the reversal agents. Another interesting thing that can happen with heparin is actually this immune phenomenon called heparin-induced thrombocytopenia. So if you ever hear of HIT, that's what we're referring to, as patients can develop this. This is a relatively low percentage, but you need to be really careful and be able to monitor for it. This is for patients who are long-term heparins. They may be on it for a couple of days while they're inpatient. Maybe they develop the PE. They're having them up there in the med-surg floor, the ICU, wherever they happen to be. You're on the heparin for several days. This is something where you're going to find that they will develop an immune reaction. Basically, they develop an antibody to heparin and something called platelet factor 4. And what that does is it actually will activate platelets. So it's a thrombocytopenia, but it's only thrombocytopenia because we're actually activating all these platelets. The antibodies actually will start to activate platelets, and when you activate platelets, what happens? You get clots. So they basically have clots that can develop all over, even though when you measure the CBC, their platelets look low, but it's because all the clots or the platelets are basically being tied up, and these little clots are happening all over. So not good. Can be potentially life-threatening, as the case may be. So you need to monitor for this. So we do things like monitoring for drops in platelets from day to day. So we're usually monitoring CBCs pretty frequently, things like that. In which case we actually have to give alternative anticoagulants, things that are non-heparin based, in order to make sure they still stay anticoagulated, because now their platelets are starting to bind up. But we also need to give them something that's not going to re-aggravate that heparin-induced thrombocytopenia. So we're going to see there's some cross-reactivity with some of these agents here. We'll learn which ones are safe to give for a patient with a history of HIT. We'll learn which ones are not safe to give. Because again, I don't want to re-challenge a patient who has HIT with more heparin, because they're going to have another reaction, right? They already have the antibodies developed there. Yes, sir. The CBC will not be normal, but you'll see the platelets dropping, right? So you'll find that they'll be thrombocytopenic, but it's not that it's like they've destroyed all the platelets, just they've now been all activated, and so they're not actually directly circulating in the bloodstream to actually measure, the case may be. So yeah, so it'll definitely be abnormal in those cases there. Anyway, so we're going to find that We're going to give a couple of drugs here. We'll talk about these a little bit later. These are going to be some direct thrombin inhibitors we're going to administer, and then we'll talk about low molecular weight heparins here in just a few minutes. But basically, just kind of keep this in the back of your mind that HIT is something that happens most predominantly with heparin, regular unfractionated heparin, but it can happen with other agents that fit within this class here. Okay, so looking at going from unfractionated heparin, saying we have a big, long, giant sugar molecule, we can kind of chop it up a little bit into smaller pieces and still get some pretty good activity out of it. And this is where we get our low molecular weight heparins from. Low molecular weight just means we chopped up the larger heparin molecule into smaller pieces, and it still has some activity. The activity changes, but it still is a pretty good anticoagulant agent here. Okay, and so if you imagine, the mean monosaccharide sequence here being about, say 5,000 Daltons here. By chopping it down, we get roughly fragments a third of the size of unfractionated heparin. Several ways we can do this, but basically we end up with these drugs. And the primary one, and actually the only one I've ever actually seen used in the hospital, would be enoxaparin or Lovenox. I'm sure a lot of people have heard of Lovenox before. There's other ones called dalteparin and tenzaparin. I haven't seen them, so I don't know if they're how frequently they're used. It just depends on the hospital formulary. Everywhere I've ever worked has been enoxaparin as being the lead one there. But we'll see how the activity differs a little bit based on chopping up and using a shorter sugar molecule there. So basically, they have the same activity as heparin. Oh, yes, sir. Yeah, so the low molecular weight heparins still cannot go through the GI tract, so these are still going to be parenterally administered. Most often, these are going to be given subcutaneously, maybe IV every once in a while, but these are going to be more predominantly going to be given subcu. And again, I'm not going to test you on routes necessarily, unless I really kind of harp on it for pretty clear reason there. But just know these are going to be parenteral agents. That's probably good enough. I wouldn't delineate between IV and subcu necessarily. Anyway, what you're going to find though, and I'll show you a picture of this in just a second, how this differs from unfractionated heparin, but you tend to find that the activity differs a little bit to where you're going to find that this doesn't really affect 9, 11, and 12 quite so much, but remember we said that 10 and 2 are the most important ones. You actually find that they have a lot more activity against factor 10 and a little bit less activity against factor 2. So if you were to look at unfractionated heparin as being a ratio of 1-to-1 activity and as inactivating 10 and 2, you're going to find that the low molecular weight heparins like enoxaparin or Lovenox has probably like 2 to 4 times more activity against factor 10 than it does against factor 2. That's going to be important when we get to the monitoring and how we're actually going to be looking at the dosing and all these sorts of things. Okay. So if you were to look at, say, low molecular weight heparins, then it's going to be a little bit shorter molecule here, working with antithrombin still, so the same mechanism. You're going to find that it can still interact with factor 10A pretty well. It can still is long enough to kind of encapsulate both of these, but when you get to factor 2, you really can't do the job quite so well. Well, some activity against factor 2, but not nearly as much as a normal heparin would. Okay, so really this is affecting factor 10 more predominantly than 2. So again, typically given sub-Q. The nice thing about the low molecular weight heparins versus heparin is that these are typically just going to be kind of weight-based sort of dosing versus heparin. I was having to do like consistent monitoring to adjust my level and give these kind of via continuous infusion. Most of the time I can give Lovenox and give it 1 time a day, twice a day, depending on the indication, and I don't have to think about it. You don't have to do routine monitoring for enoxaparin like you do for using unfractionated heparin. So that was a big plus for it for a long time. It's like, well, it's nice because I don't have to think about it. I can just give a dose based on the weight. I don't have to think about monitoring APTT. And in fact, you can't monitor APTT because it will not be reliable as showing you what the actual effects are going to be here. However, there are some problems with it. Namely, you really have to look at the renal dose elimination for this drug. So if you have a patient with poor kidneys, they're not going to be eliminating this very well. You have to be able to monitor for that to make sure you're not getting them too anticoagulated. And so in those cases, you have patients who are maybe either at the very extremes of weight. So say you have a very heavy patient or you have a very light patient for their age. We may do this for pregnant patients. Anyone who's really high risk, we would want to go ahead and monitor. And what we're going to use is a lab assay called the anti-factor 10A. So instead of APTT, which we would monitor with heparin, anti-factor 10A is what's going to be useful for this drug, which makes sense because what do we say has more activity against? Factor 10. So we're going to use an anti-factor 10A level, and this is going to help us out, right? So for instance, if you work like in a typical adult sort of unit, you're going to find that you don't really do anti-factor 10A monitoring too frequently. It's still kind of expensive. But if, say for instance at Nemours, any patient we have, because peds are going to be a higher risk population, we do anti-factor 10A monitoring for every single one of them. Okay. So again, if I were to ask you on a test, what's the primary monitoring parameter for Lovenox, you'd be able to say anti-factor 10A. Other nice things, less bleeding than heparin typically. It has a lower propensity to cause HIT, but still can cause it, okay? And also, there's some cross-reactivity here. So if I had a patient who had a history of HIT, I would not want to give them enoxaparin because I could have a cross-reactivity, could still activate those antibodies, and then I could have another episode of HIT. Okay, you don't want that to occur. We typically do not like to hit our patients unless they really deserve it. Maybe if you're doing like CBT therapy with those little Nerf baseball bats or something. I don't know. Anyway. Okay, so moving on, the next drug we have here is going to be fondaparinux or Arixtra. This one is even a shorter molecule than a low molecular weight heparin like enoxaparin is. And the nice thing about this one is it actually has only factor 10A inhibition. So it actually has no activity against 2, just going to be affecting 10A. Okay, so this would be a direct 10A inhibitor. Again, given subcutaneously. The nice thing about this is that we has very, very low incidence of HIT, and actually in some patients who have a history of HIT with heparin, we can actually give them fondaparinux and they don't have any cross-reactivity. So that's another kind of nice little niche that fondaparinux is going to fall into. In similar indications, you know, so again, prevention of clots after things like surgery, active treatment of clots that have already occurred here, like VTEs or PEs, things like that. So the indications are all the same. The other thing to note here is that it's very renally dependent on its elimination, so you got to watch and make sure you're adjusting the dose for that. Now, if I had to monitor for activity here, what lab test would I use? It's still use anti-factor 10A, because again, this is only affecting factor 10A, right? So anti-factor 10A is going to be the primary monitoring for this drug. Okay, so now we have a couple of drugs that are going to be, these are IV agents that we're going to be using, and this is oftentimes the drugs you're going to use for patients who develop HIT. These are called direct thrombin inhibitors. So if you had to guess what the mechanism is, you'd say they inhibit thrombin, which is factor 2, right? So again, instead of just having any just primarily factor 10 activity like fondaparinux did, now we're switching over and we have drugs that only have activity against factor 2. So these are very safe to give for patients who have HIT, and that's oftentimes where they end up being administered here. So we have 3 of them we're going to be administered, 3 of them that we have. We have lepirudin, bivalirudin, and we have argatroban. It'd be nice if they all had the rudin on the end of the name there to help with memorization, but unfortunately that's not the case. Interestingly enough, though, they actually are based off of Hirutin, which is a product that are produced by leeches. Yes. So does anyone know, or did anyone know that we still use medicinal leeches occasionally? It's super gross. Mainly because where do you think they get kept? In the pharmacy. And guess how they smell? Not great. They also like to escape very frequently. So maybe we should keep some next to Swim Shady. Maybe that would have be good bedfellows. But yeah, so they like to get out, and they're actually very, very expensive. One hospital I was rotating at, they had a bunch of leeches. They had a specific patient who needed it for whatever reason, I can't imagine. But basically they needed those leeches, and one of the pharmacy technicians didn't know. They saw it and they were like, oh, this thing smells, it's kind of gross, and decided to flush the whole thing down the toilet, and so ended up wasting like thousands of dollars worth of leeches. They were got a very firm scolding from the director of pharmacy.
How much do leeches cost?
They're pretty expensive. I don't know the actual price, but they're a specialty item. I mean, like, how many leech farms do you run across, driving down the road? Not too many. Maybe that could be a special market you can get into if you had entrepreneurial sort of aspirations, but definitely not my cup of tea, right? If I had my own leech farm, I would probably have like the tagline like, "We really suck." Anyway. Okay, so again, sorry, no humor. That's the goal today. And getting back to as far as monitoring goes, because we are focusing on things that only affect factor 2 with these drugs, now APTT is going to be the thing we're monitoring again, right? So again, activated partial thromboplastin time is going to be much more dependent on factor 2 activity, so that's why we use APTT here to monitor. And again, very similar sort of monitoring parameters, usually getting 1.5 to 2.5 times the normal APTT ratio there, and then adjusting the infusions based off of that. Okay, and again, oftentimes we're going to be choosing which one we give based on how good the kidneys are. If the kidneys have poor function, then we oftentimes will give our argatroban instead. But again, very similar activity amongst all these. And if you had to guess side effects, the biggest one being still bleeding, right? Because again, we're still factoring factor 2 here, right? Okay. Up next, we have warfarin. Who's heard of warfarin before? A lot of people. It's a very old drug. It's been around for decades and decades. Does anyone know where the name comes from? On the slide here, it's actually named off the Wisconsin Alumni Research Foundation. I don't know how they got warfarin specifically from that. I guess either the wharf, but anyway. was kind of interesting. They actually had they had cows that they had there, and there was some grain or some kind of greenery they were eating that actually became spoiled, and they developed these hemorrhagic disorders in these cows. So I guess these cows were like bleeding out or developing these big bruises and stuff, and they're trying to figure out what the heck it was, and they actually found dicumarol. Right? Dicumarol is kind of the first chemical in this kind of compound we found, and then since then, and again this is back in the 1930s, we've been using it as a rodenticide. You know what that means? Kills rodents like rats, mice, capybara, which are the world's largest rodents, if anyone knew that. I watch a lot of Planet Earth with my kids at home. Just kidding, I wouldn't use this on capybara, they're too nice. But yes, if you had rats or something. So we still use this as a rodenticide. And in fact, if you go and look at, if you were to look at rat poison and things like that at the store, you'd actually find dicumarol or brodifacoum, things like that are still in use today. Anyone know why they work for rats? Yeah, they don't have a vomit reflex, they can't throw up. So even if they knew it was kind of poisonous, they can't throw up, and then they bleed out, and then you have dead rats. Anywho, I digress. But we've since realized that this actually has pretty good anticoagulant effects for people. So we have been using it for decades and decades. It's been around much longer than any of us have for sure. So looking at this, we're going to find that warfarin itself is actually a racemic mixture, but we're going to find that actually the S enantiomer tends to have a lot more activity, about 2 to 5 times that of the R enantiomer. And that's going to be important when we're talking about CYP enzyme interactions here in just a few minutes. So again, CYP is going to rear its ugly head again. The mechanism here, so this is a novel mechanism compared to a lot of the other agents we've been looking at. We've been looking at drugs that either directly inhibit the coagulation factors, maybe hasten their destruction with things like antithrombin 3. This actually works on the production side. So this is actually working directly within which organ produces clotting factors? The liver. So this works within the liver. It's actually going to be a vitamin K antagonist, right? Anyone know the other name for vitamin K? Not potassium. I get one person every single year on that in biz. I love it. It's like heroin almost. Yes, I got him. Just kidding. I don't like to do that. Anyone know the other name for vitamin K? Phytonadione. You ever see phytonadione? That's what that. And it's good to know other names for all of these vitamins and things like that. For instance, like vitamin D. Cholecalciferol, ergocalciferol, those are different forms of vitamin D, right? So sometimes it's good to know some of these other names because you're going to see them, in the hospital, right? So again, you may not be able to search for vitamin K. You may have to put in phytonadione in order to get a vitamin K, and we'll talk about when to use that in a little bit. Anywho, this is a vitamin K antagonist or phytonadione antagonist, and basically this is going to be blocking the production of factors 2, 7, 9, and 10. Okay, so 2, 7, 9, and 10 are going to be for warfarin. We saw for heparin was what? 2, 9, 10, 11, and 12, right? So here it's going to be 2, 7, 9, and 10. The other big thing of note here is it actually is going to be inhibiting production of protein CNS. And what did we say about CNS a little bit earlier? Yeah, these are actually natural anticoagulants already, so we're going to see that that's going to have some clinical impact here in just a little bit. But basically, the liver is going to be using vitamin K to synthesize production of these clotting factors here, and warfarin is going to come in and basically inhibit the recycling process here. So that way, the vitamin K that gets used to make a clotting factor cannot be reused. And until you get some more vitamin K coming in from the GI tract, you're not going to be able to make any more clotting factors out of that. Okay. So as far as activity goes, as far as like onset of action, which do you think is faster, something like heparin or something like warfarin? Heparin, why? Yeah, I can work with antithrombin 3 to inactivate these clotting factors immediately, right? So I can give heparin infusion immediately. It's going to be able to directly inhibit those clotting factors. With this one, it's going to take a while to kick in, right? So it's going to take some time before it really starts having anticoagulant effects because it does not do anything to already formed clotting factors. You have to only work on the production side. So you have to use up the clotting factors you've already made, and then it'll start to kick in. So this actually does not have good onset of effect until a couple of days. Like it takes 2 or 3 days before warfarin's really kind of at full effect by inhibiting the production of these clotting factors. That's one important fact to remember about warfarin as far as how the activity works. Okay. Just another slide kind of showing you the same thing here. I was working on this vitamin K oxide reductase. That's the enzyme specifically that warfarin is working against. Okay, so we're going to find that when you have therapeutic levels of warfarin, you're going to be able to decrease synthesis of those clotting factors by about 30 to 50%. So it's not 100%, right? Because otherwise, if you had no clotting factors being made, your patient would bleed out and die, right? We don't want that to occur. And again, that's obviously going to be the biggest risk you're going to see with warfarin there. Now, again, no effect on already formed factors. We'll not do anything like that. And again, I mentioned that delay in onset. It's very, very important. Now, looking at the half-lives of some of these clotting factors, this makes a lot of sense, right? So, for instance, looking at things like factors 2 and 10, they have a relatively long half-life, right? So that's why it takes a couple of days where you really start to see the effects, the anticoagulant effects actually kick in here. However, for instance, protein C, you notice here that only has about a 4 to 6 hour half-life. So initially, what you can actually find is that at the very beginning, patients that can actually have a procoagulant sort of situation before they have a more anticoagulant effect, right? Makes sense because you're losing out on this anticoagulant initially. You still have all these clotting factors around, you can still clot off, but then eventually once you kind of decrease production of everything else, and so the half-lives have run out, then you find that you have more of an anticoagulant effect. That is why, has anyone ever heard of bridge therapy? It's something that's going to be important when you're looking at patients who have already developed an active clot. So if you have someone who develops a PE or someone who developed a deep venous thromboembolism who are being treated with heparin, you can't just stop the heparin and then start them on warfarin, because initially you're going to find that one, the warfarin doesn't kick in that quick, and that you actually have a procoagulant sort of effect very initially. So you may actually worsen that clot that you were trying to treat with the heparin in the first place. So what we do is what we call bridge therapy, where we're going to have them on heparin. A couple days later, we're going to start them up on the warfarin. They'll be on both drugs for, say, 2 to 3 days, and then you'll cut off the heparin, and then the warfarin will be having its full effects at that point. Okay, it's called bridge therapy, and something that's very important. If you miss that, you can actually worsen the patient's clot, or maybe cause a new clot to occur, as the case may be. Okay, especially those patients who have a kind of a congenital sort of like procoagulant sort of effect. If they have a protein C deficiency or something like that, right? So anyway. Anticoagulant effects usually within the first 24 hours, you're going to start to see that, and full antithrombotic effects by 5 to 7 days or so. Okay. So anyway, warfarin only given orally, very good absorption. It has a pretty long half-life for the most part. Now, things to note here is that as far as drug interactions go, and there are numerous drug interactions with warfarin, which is why it is so important to make sure you check these interactions if you ever see a patient on warfarin, is that when it's highly protein-bound to albumin, about 99%. Okay, so what do you think would happen if I had another drug come along and kick albumin off of that albumin? Say I went from 99% bound to 98% bound. Well, what do we say about which is the active portion of the drug? Which one's physiologically active? Unbound drug, right? If it's bound to albumin, it can't really interact with the liver at all. It needs to be unbound. So if I went from 99% to 98%, that doesn't sound like very much. That's a doubling of the physiologically active amount of warfarin there, right? That means you can have a doubling of the anticoagulant effect potentially, right? So you have to be really careful with that. So again, any interaction where something is going to kick warfarin off the albumin because they're competing for the same sites can cause potential bleeding problems, right? The other thing to note here is that they're metabolized in the liver. Some of the big interactions here, CYP3A4 plays a small role here. 1A2 plays a small role, but the big one we want to focus on is that S-warfarin, which we said has more anticoagulant effect, is metabolized by CYP2C9. So if you have anything that comes along and inhibits CYP2C9, warfarin effect is going to go up, right? If I have a CYP2C9 inducer, what would happen? Make it go down. Okay, good. So keep those interactions in mind in a few minutes. All right. Now this is actually going to be contraindicated in pregnancy. So if you had a patient who is pregnant who needed anticoagulation, warfarin is not going to be the drug for them. It's categorized as a category D. We'll talk about pregnancy categories later, but D is not good. It means you're going to have definite fetal harm that can occur there. Okay. Okay, so the big interactions to note here, you have to be really consistent with vitamin K intake, okay? So knowing that warfarin inhibits vitamin K utilization within the liver, what would happen if I were to, say, eat a whole bunch of, say, broccoli and collard greens?
But you'd be more likely to clots.
So I would be absorbing more vitamin K. That would mean I could do what at that point? I would make more clotting factors, right? Because again, warfarin inhibits the recycling of vitamin K. So if I'm absorbing more vitamin K, I can make more clotting factors, and that means warfarin's effects will go down, right? So I'm inhibiting the effects there, okay? What would happen if I ate say collard greens every single day, and then say I stopped? I said, I don't want to eat this salad anymore. What would happen at that point? I have less vitamin K being absorbed through the GI tract, less vitamin K going to the liver, clotting factor production would go down, and what would that mean for my warfarin effect? It would increase, right? So you'd find the patient would be more likely to bleed, right? So again, this is very, very diet dependent. Very, very drug interaction dependent on the effects here. Again, this is why for a good long time, this was a very potentially dangerous drug. It was very hard to work with, but for a long time, it was the only oral agent we had for long-term anticoagulation. So we were kind of stuck with it. And in fact, a lot of the rotations you would do as a pharmacy student on the community side was working in warfarin clinics. My first rotation I ever did was at a warfarin clinic, bringing in patients. We test their INR, which we'll talk about monitoring in a minute, and trying to adjust their dose to make sure they were well anticoagulated. Now we're going to see there's some newer alternatives we'll talk about in a second, but just know that you really have to make sure you're consistent with their vitamin K intake, right? And so, of course, I was doing my rotation in Palaca, Florida. Anyone familiar with Palaca, Florida? I know at least one. Anyone? I see exactly. No one's ever heard of it. Okay. Well, yeah, 2. Okay. 3, 4 total. Fantastic. Well, it's a small town, right? And a lot of people like to grow their own food. They like to eat a lot of collard greens and spinach and all this kind of stuff. So managing warfarin for them was very, very tough. And especially if they had low socioeconomic status, their access to food may be variable from week to week. And so it was very tough because you had to make sure that, hey, you need to be consistent with this. You can't just go from eating spinach all day one day and then nothing the next day. You have to make sure you're at least eating a consistent amount, right? Some people mistakenly think, well, I can't have any vitamin K. That's not the case. You just need to be consistent with it, right? So again, it's not one of those things where any vitamin K is going to throw you completely off, but just be consistent from day to day, and that's going to keep you out of trouble for the most part. Okay. Again, anything altering the metabolism of CYP2C9 is going to have a big role to play here as well. So if I inhibit CYP2C9, levels of warfarin are going to go up, and it's going to cause more anticoagulant effect. I'll give you guys a break in a second. I just want to finish up the warfarin stuff first. But any additional vitamin K I'm administering, maybe through multivitamins or something that could affect this. And then the other thing to really note here as well is that where does a lot of the vitamin K that we absorb to the GI tract come from? The gut, but primarily what helps to absorb that in the gut? The gut biome, right? The bacteria that are there. So antibiotics can have a big role to play here. And actually, one of the biggest ones that we worry about is actually Bactrim. Because if you remember, Bactrim was the sulfamethoxazole and trimethoprim, inhibited which CYP enzyme? 2C9. And it also does what to the gut flora potentially? Kills some of it off. So by 2 mechanisms, you can actually find that it's very, very dangerous to put a patient who's on warfarin on Bactrim without adjusting their dose down. Very frequently, it's cut their dose in half. Otherwise, their INR is going to skyrocket. Okay, you're going to see that can be very, very bad for the patient from a bleeding perspective. Okay. Someone had poor liver function to begin with, again, they're going to have a harder time making clotting factors. They may be also more sensitive to it as well. Okay, so how we monitor this is going to be through our PT/INR. Okay, INR is the main thing you're going to use to monitor the effects of warfarin. Basically, PT is prothrombin time. INR just stands for the International Normalized Ratio. Every lab will have a little bit different value that gets produced, but by using this normalized ratio, this is how we can compare INRs that are produced from any lab in the world all together, and they should be equal as far as their effects go. Okay, now normally, what should a normal patient's INR be? A normal should be 2 to 3.5? 1. Everyone should be 1 if they're not on warfarin or any sort of anticoagulants, right? Because the patient reference is compared to kind of the standard sort of lab reference, right? So again, if you have no anticoagulant effect, you should be at a level of 1. Okay. As I put a patient on warfarin, that ratio is going to go higher because that bleeding time increases, right? Because again, their blood's anticoagulated, they're going to have a longer time it takes for that blood to clot. That level is going to go up. So for treatment, typically we're shooting for an INR of 2 to 3. An important number to remember. 2 to 3 is the reference range for most patients who are on warfarin. Okay. Now there are some cases where we need to go a little bit higher. Those are going to be really extra, large thrombotic risk. The big one that I always think about is going to be mechanical heart valve. Right. If you have a mechanical heart valve, those again bare metal in the heart, very prone to developing clots. You have to shoot it up for higher levels. That in that case would be like 2.5 to 3.5, basically. Yes, sir.
Bleeding time goes down, or just like
it should get longer, right? Because again, as I'm being anticoagulated, it's going to be longer for that blood to clot. The time it takes. Okay. Yep. So that's why the ratio gets bigger in this case, not smaller. Because again, my patient's bleeding time who's on warfarin is going to extend out and be longer than would be for the normal reference range, right? So again, 2 to 3 for most patients who's on warfarin, 2.5 to 3.5 if you had a very high risk thrombotic sort of patient or high risk for developing thrombosis, 2.5 to 3.5 in those cases. Okay. Just remember those numbers. Okay, as I talked about that, and again, some patients have pharmacogenetic differences. Remember we talked about pharmacogenetics just being those genetic factors that may predispose you to having altered pharmacodynamics or kinetics. In this case, you can actually have patients who have different alleles for CYP2C9, they may actually have poor metabolism. So in this case, say 10 to 20% of Caucasians, maybe less than 5% of African American patients may develop these alleles where they actually have less efficient metabolism. What do you think that would do to the effects of warfarin? it would increase it, right? So again, say for instance, I had a patient who was started on warfarin. They had a poor, metabolism allele for CYP2C9. What would I expect the INR to do? It would actually go up in those cases, right? Because I'm inhibiting. I have more warfarin around. It's not being metabolized as well. It sticks around for longer. I have more inhibition of vitamin K synthesis of clotting factors. INR should go up at that point. Okay. So it's good to know. If I were to ask you a test question, I said, hey, you have a CYP2C9 inhibitor on, or a patient went to an all-kale diet, or whatever, how that is going to affect the INR. Okay. So for instance, if the patient said, you know, I'm just going to eat a spinach diet every single day, morning, noon, and night. It's all going to be nothing but spinach and kale for me. I'm going to be healthy finally. Okay. What would that do to their INR? It would decrease the INR, right? Because again, as I'm getting all that vitamin K coming in, I'm producing those clotting factors, I'm getting back closer to normal production of those clotting factors. There's so much vitamin K coming in, that INR is going to get down lower to what the normal patient would be, right? So that ratio gets smaller and smaller, closer to 1, okay? And thus they would be at risk for developing, a new thrombosis. So, and again, the biggest place you see this used most frequently is going to be for AFib, right? Because again, we know those patients tend to be a high risk for developing clot when you have that little atria just kind of sitting there quivering, you have that the pooling of blood that occurs there, right? Other patients may be on as well if they need long-term prophylaxis of clots. So there's a lot of places we're going to be using warfarin for patients. Okay. I mentioned bleeding is going to be the biggest risk to watch out for this. Again, if you keep them within the normal range, say 2 to 3 for a therapeutic treatment, you're going to find that bleeding, serious bleeding, less than 5%. As you start to get higher and higher ratios here, greater than 4 is when you start to see things like intracranial hemorrhage. Greater than 5, you see this is where we're going to be a big risk. This is where we need to think about reversing the drug, okay? So here we're talking about reversal agents. We're going to be finding that vitamin K or phytonadione is what we're actually going to be reversing it with, okay? Now again, do you think it's going to have an immediate effect? No, because the vitamin K just helps us to produce new clotting factors. It doesn't actually help us to provide new factors for the patient. So in those cases, what could I do? Well, I could actually give things like fresh frozen plasma. FFP already has clotting factors in it from donors. I can administer that to the patient and actually replenish the factors they're missing and have an immediate reversal of that warfarin there, okay? It doesn't work with every drug. Now again, could I give FFP to someone who had, say, had an inadvertent overdose of heparin? Would that necessarily work? Why not?
Because that already had a direct effect.
Yeah, because the heparin is just going to start to inactivate the clotting factors that I'm administering through the FFP. So that in that case, you find that it doesn't really do you a whole lot of good. Versus with warfarin, because it's only working on production, I can supply exogenous factors and then reverse that very quickly. Okay, so kind of keep that in mind. It's not just the drug vitamin K we're giving. We'll give that to help the liver start to produce more clotting factors, but we oftentimes, especially if they're having a serious bleed or something, we can give them FFP to help kind of reverse that effect. Okay. One thing to note that I did not mention is that protamine is really just for unfractionated heparin. It has very minimal effects on things like Lovenox. Has almost no effect whatsoever on things like Arixtra. Okay. So just be aware of that. So again, if I ever point out a specific reversal agent, those are fair game as far as what's on the slide there. Okay. All right, so anyway, any questions from the first half there? All right, so warfarin, as I mentioned, we've been using it for decades now, and it's a very effective drug. It's very good, but man, it is such a bear to work with because monitoring is so frequent and so diet dependent. There's so many drug interactions. Very frequently, whenever we started a patient on warfarin, we'd have them come back in every single week for several weeks until we actually got them into range, and then we had to show that they stayed in range for at least 1 to 2 weeks, and then we can start to extend it out. So some patients you can get to where maybe see them like once a month, once every 2 months or something like that. I had one patient, and one thing you'll learn when we talk about HIV is that many of the drugs there have significant CYP drug interactions, some on purpose, some not so much. And so I had a patient who had Hep C, HIV, and AFib and needed warfarin for that. And I tell you what, he was the most difficult. I was in that clinic for 2 months, and it wasn't until the very last week that I was able to get that patient into the actual range. Because again, things like diet, things like these drug interactions were just playing a role in preventing you from really getting the INR into range. So it was a very tough drug to work with for a good long time. However, the one nice thing about it, though, it's easily reversible. If I have someone who falls, hits their head, and they start having intracranial bleed, I can give them FFP and vitamin K very quickly and get that warfarin reversed. Okay. Keep that in mind when we start talking about some of these newer drugs here. These are called the new oral anticoagulants, or NOACs. If you've ever seen NOACs, that's what we're talking about there. And so this is going to include dabigatran, it's going to include rivaroxaban, and then apixaban. Okay, so we'll talk about how these mechanisms differ a little bit from warfarin here. So anyway, so looking at dabigatran is the first one here, or Pradaxa is the brand name. This is actually going to be an oral direct thrombin inhibitor. Now, if you remember, we talked about some thrombin inhibitors before, like bivalirudin and leparudin. Those are IV only. That'd be given via continuous infusion. This is actually going to be an oral agent that we can administer. And again, it's going to be preventing that conversion from fibrinogen over to fibrin by inhibiting factor 2, right, as we remember. And thereby you can't have that nice that positive feedback loop where 2 would go back and then activate things like NO5 and 8, etc. So very good as an anticoagulant agent, useful for things like DVT, PE, AFib, anywhere we could use it for where you could use warfarin. You could also use this as well. Kind of fit that same role. The nice thing here as well, there's no real routine monitoring. Being a factor 2 inhibitor, we could maybe measure APTT, but there's not really a good linkage between the actual anticoagulant effect, the dosing we administer, and APTT monitoring, so you don't really do any monitoring. So that's a huge plus for patients who don't want to keep coming back in and have their PT-INR checked all the time, right? However, you're going to find that the adverse effects include obviously bleeding. There's going to be a big thing there. And the question is, well, how can I reverse this, right? So if I had a patient who had a fall and they were bleeding, or maybe they take too much dabigatran, how can I reverse this? And actually, there's no real good way to do that. Even if I give FFP, you're going to find that if by giving FFP and I give more factor 2, guess what the drug's going to do? It's a direct thrombin inhibitor, so it's just going to go and inhibit it. So it really doesn't help me a whole lot in those cases. It can be very difficult to treat until they actually had a reversal agent that came out, and it's called idarucizumab. So automatically you know that it's what? It's an antibody, and it's going to be targeted directly against that dabigatran. So it can actually go, and it's what's called Praxbind. It basically can go and bind up Pradaxa directly and inactivate it. So that's all well and good. And can you guess who is the manufacturer of the reversal agent? Same people that make the drug itself. Interesting how they make a drug that can't be reversed unless you buy our reversal agent. Not that I'm saying you should be cynical against the pharma companies. I'm just saying. Anyway. And again, it's a really expensive drug. You know, I can get vitamin K very cheap compared to something like this Praxbind. A lot of places may not carry it, right? So again, you want to be careful, and you never want something like, you know, whether or not my mom dies from a head bleed because she fell and hit her head on dabigatran to be, well, did she get taken to this hospital that has a Praxbind or this one that doesn't? So it's one of those things where it's like, you know, depending on the patient, it can be a really good drug. Some patients, though, especially those that are more elderly, more that are likely to have falls, things like that, tend to be not as good a candidates for this, I would say, right? So be careful with that. Again, you do have to watch for renal function because, again, it will can adjust how often you need to give it or how big of a dose you need to administer, right? Now, if you did have someone who's having active bleed, you could try to do something like dialysis where you hook them up to you know, a dialysis machine to pull the drug off. But guess what happens when you put a big fat dialysis catheter into a patient and they're on Pradaxa? They bleed a lot, right? So again, it's one of those things where you have to be really careful, like, well, do I want to cause them to bleed more by putting this in? Yeah, so not done frequently, but just watch the renal clearance from that standpoint. Two other ones we use pretty frequently have rivaroxaban, and then apixaban is also going to be on the same mechanism here, but these are going to be oral 10A inhibitors. So functionally, you can think of rivaroxaban and apixaban as being functionally equivalent to Arixtra, that fondaparinux. Notice there's a lot of X's in these names because they're working against factor 10. This is the oral alternative to that, essentially, right? So again, useful for AFib, DVT, the same place you use warfarin for, basically. And again, no routine monitoring, so very nice from that standpoint. You don't have to come back into the Coumadin clinic every week to get checked, right? Now with this one, you're going to find that because it's not directly inhibiting thrombin, you can sometimes get around you know, bleeding risk by giving something called prothrombin complex concentrate. This is actually like an even more concentrated form of FFP, where it's just basically the clotting factors, namely 2 is the big one you're really concerned with there. Because again, if I can bypass 10 and just give the actual 2 factor, sometimes you can help reverse some of those effects there. So that can be a potential reversal that you can use with that. Okay. Again, this one, while it's renally eliminated, doesn't really have any dose adjustments kind of noted there, so that can maybe be good for patients who have maybe poor kidney function. Apixaban is going to be the same thing. Again, another oral factor 10A inhibitor there. Now, potentially you could monitor with something like anti-factor 10A, but the nice thing with these drugs, you routinely don't have to. As long as you give a kind of a fixed dose for your patients based on their weight, things like that, you usually don't have to worry about monitoring, which is nice. Now, this one is a little bit unique because it is metabolized by CYP3A4, so you do need to be careful, because if you have someone who's on a 3A4 inhibitor, watch out for that, right? So again, if I had someone who's on apixaban routinely and all of a sudden they get, say, a walking pneumonia, worried about atypical bugs, give them something like, was an antibiotic that inhibited CYP3A4 that covered atypicals. macrolide, right? If I give them something like erythromycin, I could cause this levels to go up pretty significantly. All of a sudden, their bleeding risk goes up as well. Okay, see how everything kind of comes back? That's why we talk about these things frequently, right? Okay, so those are the major anticoagulant drugs you're going to be running into. Get familiar with them. They're going to come up again and again as we get into different disciplines. We're going to talk about them in cardio for sure. We're going to talk about them more as we get into things like ortho, because again, oftentimes you're worried about prevention of clots in those patients. So this stuff will come up again. Okay, any questions? If not, I'm going to go on and start with cardio part 1.